Yeah, there we go. There they are again. I think it's because I was the last one to send them over. That's why they kept popping up for other speakers. So thank you, Duncan, for the kind introduction and for the organisation to invite me here to speak to you about how we can consider health equity when designing and conducting digital clinical trials. A couple of things I want to talk to you about in those 20 minutes that I've got. So I want to briefly introduce digital health equity. So what do we mean by that term? So just to make sure we're all on the same page, but also why we should care about it. Who are at risk of experiencing those inequities in digital trials? So how can we think about the populations, the subgroups that we have to consider? And then the last one is to come up with some solutions to that problem. So how can we think of approaches to make sure that we reduce the equity impact of digital procedures and digital tools that we use in trials? So let me start with the introduction. So if we talk about definitions, I think this is a really good definition to start from. So it's the World Health Organization definition of health equity. And I think there are two parts, and they're equally important. So the first part is what we mean with inequity. So it's about differences between groups that are avoidable or remediable and unfair. And we can define those groups in different ways. So socially, economically, geographically, or demographically. And I'll talk a little bit about those characteristics in more detail later on. But the second part is equally important. So the World Health Organization says that we can achieve health equity only by making sure that people can attain their full potential for health and well-being. And that's actually what the picture on the right-hand side tries to express. So it's trying to explain the difference between equality and equity. So on the right-hand side, it's equality. It means that we give everybody the same support to, in this case, pick an apple from the tree. So in your case, it might be to benefit and take part in a digital trial. And there's nothing wrong with equality. It's a really good principle that we try to give everybody the same thing, regardless of their background. But when we think about equity, we actually start on the other end. We start thinking about with what do we actually want to achieve? And in this case, we want to make sure everybody can pick an apple. And then from there, we start thinking, okay, what is it they actually need to do that? And then you can see it becomes different. So it doesn't mean we need to give everybody the same height of crate, because the tall people don't need such a big crate, but the small people do. So it's really thinking about the needs of particular groups of people in order for them to take part in your digital trial. So when we then take health equity into the context of digital trials, I think that we can consider equity at different stages, levels, aspects of trials. So the first one is equity in the design of trials. So we need to involve people in designing procedures, designing the interventions, designing the follow-up to make sure everybody can then have equitable access to those trials. So I think Rosalba's talk is really about, so remote consent can be a massive barrier for people to take part in. Careful consideration of designing e-consent modules and apps becomes key in order to ensure equitable access. But once people are in, we need to make sure that they can actually do the follow-up. So make sure that the data collection procedures that we employ, for example, engage everybody and make sure that we can make it till the end of the trial. And I guess the last and obviously most important stage is that everybody can have an equitable experience of taking part, but also has equitable outcomes and benefits. Because if we don't get the other stages right, you can imagine that the trial will not deliver the results that everybody can benefit from. So just to answer my question about why should we care about this in the context of digital trials, I brought this example from another specialty. So it's a cardiovascular trial that was done a couple of years back, and it was comparing different doses of aspirin for people with cardiovascular disease. I'm not going to talk about what the trial found, but I brought it because it allowed people to choose whether they wanted to participate online. So that meant they had an email reminder for their next follow-up visit, and that visit was done remotely, so via video consultation. But they could also opt for non-online participation, and then they were given a phone call to invite them to come to the hospital for that visit. So people were just given the choice of those two ways of participating. And it's interesting because then that allowed the trial team to compare these two groups. And what they found is that the people who opted for the non-internet participation were different in terms of their demographics. So they were more likely to be older, female, and from ethnic minority backgrounds. But they also had poorer health at baseline, so they had more comorbidities and more complex medication history. So even at the start of the trial, they were different from that internet group. But then when they went into the trial, we saw that people that opted for the non-internet participation were less likely to adhere to their aspirin dose that was allocated to them as part of the trial. They were more likely to switch dose, but also more likely to discontinue using aspirin altogether. And most importantly, they had worse outcomes. So in this case, it was more likely to die and more likely to be hospitalized. So I think this sort of illustrates really well why this is an important topic to consider. Because digitizing clinical trials, in this case by offering online participation, means that some groups might be underrepresented. And I think the paper that they wrote about it points out that these were groups that are already underrepresented in cardiovascular trials and might be very similar for cancer trials. At the same time, these are also people who are already more likely to suffer health inequities, so have poor access to health care, have poor health outcomes. So I think my point is that it's important because digital clinical trials it's not necessarily said that they do, but they could really perpetuate or even exacerbate already existing underrepresentation and health inequities by just making trials digital. So this is the reason why you have to listen to me now for the next 15 minutes. So let's think about what groups could be at risk of experiencing inequities. And I brought two lists to help us think about what are the characteristics that we could have a look at. So this is one called Progress Plus, and I think sort of an umbrella term would be that these are social determinants of health. Progress is an acronym, so that's why it's so nice. It sort of has 8 characteristics that they originally came up with, and some of them you already saw in the example I just gave from the adaptable trial. So more women, right, were in the non-internet group, but also people from ethnic minority backgrounds, and ethnicity is one of those 8 characteristics, one of those 8 social determinants. But I think quite quickly after they came up with Progress, they acknowledged that depending on which country you are, or depending on the type of trial in this case that you are designing, there might be different characteristics that matter. And so that's why they came up with this sort of plus element. And for example, age, which was a really important factor in the adaptable trial, is in the plus category. And I think for example, UK context, older people are often seen as being at risk of health inequities because they have poorer access to services, for example. And there are other sort of plus elements there that I would just summarize on, you have the flexibility to come up with additional determinants that you feel are important for your setting. So these are social determinants of health, but obviously we're talking about digital trials, and I think that's why it's important to also think about digital determinants of health. And I brought this framework because it really nicely combines the two. So on the rows of this table, you see different domains of influence. You can see lots of the things that already came up in the Progress Plus list, but they added digital environment as an extra domain. And then on the columns, you can see the different levels at which that influence happens. The individual level is the one that often, springs to mind. I think Duncan already referred to, for example, the problem of not everybody having access to a smartphone or having access to the internet, which is in this framework, an individual level factor that matters. But if we move to the right, we come to equally important but hard to solve issues. So for example, interpersonal, so people's direct environment, means that maybe people share devices with their family members, or they might have a patient-clinician relationship that doesn't really, how would you say, so the clinician or the research nurse might think that a person is not willing or able to use a digital technology, and therefore creating sort of a gatekeeper bias. Community and societal, even harder, I guess, to influence for us as researchers, but important to think about. Community infrastructures or partners, people living in cities are often closer to public libraries where there are internet-connected devices, there might be support groups, there might be courses that people can take. When you're further away from cities or urban environments, you might have less access to those type of things. And then lastly, the hardest one, the societal. I think as an example, maybe algorithmic biases relevant to Victor's talk, for example, where wearables don't have many of these problems at the earlier levels, but we know that lots of proprietary algorithms have been developed based on data sets that are not representative, often of the people that we're then trying to ask them to use. So I think digital determinants and social determinants of health are both relevant. They're two sort of nice lists, separate, but obviously they're very intertwined, so I don't think it makes sense to think about them in isolation. And this is just my attempt at showing that there's a really strong connection between those two types of determinants. And again, it's just an illustration. I could have made like 10 different slides and they would all make the same point, is that if you look at the social determinants of health on the left-hand side, they often go together with certain digital determinants. So for example, if you've got lower educational attainment, you're more likely to be digital illiterate or have lower digital self-efficacy. Those two go hand in hand often. So don't think about those determinants separate, think of them together. And more generally, in this topic, I think intersectionality is the term to make us sort of remember that we're not just our gender, we're not just our age, we're not just our ethnicity, we're a combination of things. And it's the combination of those characteristics that put us at a certain risk of experiencing inequities. So keep that in mind when going through those really helpful lists, that it's the combination of those things that matters. So now with some solutions, because obviously digital trials, in principle, are there to increase access for people. So I think we should keep that in mind when talking about this topic. I had a look, so I come more from a design of digital technology perspective. So I had a look at what is known about trials and how we can address equity or consider equity in the context of trials. And I found two really helpful papers. There are lots of them, but if you're interested in this topic, I'd really recommend having a look at those two references in the what is it, the left bottom corner. This figure here on the right-hand side comes from the Tan paper from 2022. And I picked this one because it sort of links back to the digital determinants framework that I showed. So lots of the levels that you see in this figure align with those levels of influence that the digital determinants framework also used. And they basically argue that at all these levels, there are different things you can consider when you want to support equity in your digital trial. There's no time to go through all of them. I would really get mostly Duncan and Yvonne in trouble. So I picked 3 of them. Also, taking something from my colleague Lee Agebushi in Birmingham, who just published this paper with 11 recommendations for considering equity in digital or decentralized trials. And these are the 3 ones I picked, and I'll just take you through each of them one by one. Mm-hmm. So the first one is very much at the early stages of your trial, when you're planning the trial. A recommendation that both of the authors came up with is do an equity impact assessment. And there are different ways of doing that, and I just brought one of them that I have experience using in the context of developing digital health interventions. But I think it applies really well to designing your trial, your digital trial. So it's called the Health Equity Impact Assessment, originally developed to look at the equity impact assessment of health policy, but a Canadian team then did a sort of supplement specifically for digital health technology. So that's why I think it's so nicely, it fits nicely for a digital trials context. So it's a process, so it's not necessarily a checklist, it's something that you go through together with stakeholders. And stakeholders in the broader sense, so it's not just the people in your trial, but it's also the people designing the trial, the people developing the platforms, it might be the regulators, because they can be quite a barrier, as was already mentioned. So I think that's a very broad view on stakeholders, and you involve them in going through this process. So there are 5 main steps, and I think the scoping step comes up in some of the recommendations that Lee was also mentioning in his recommendations. So scoping is thinking about who is it you're trying to include, who is the target population for your trial, and within that, who are at risk of experiencing inequities through the digital means. So that goes back to those digital and social determinants of health. Once you've thought about who those people might be, you obviously involve them in thinking about what the potential impacts can be of the fact that the trial is digital. Those can be positive or negative impacts. So, for example, an often mentioned positive effect of a digital trial is that it's easier for people to participate if they live remotely, if they live far away or they have mobility issues. Making a trial digital sort of widens participation of people who would otherwise struggle to come to the hospital. So that's a potential positive impact. But there are lots of negative impacts as well. So, for example, we did quite a lot of work with people from South Asian backgrounds in the UK, thinking about digital self-report for research. And they often have a sort of, you could say, a bigger mistrust in digital technology. So they're unsure where their data is being used for. Digital is not part of their daily lives. They definitely don't use it for their health. So that sort of makes it much harder for them to take part in a digital trial. So there might be positive and negative impacts depending on the group that you're trying to reach. And then with those stakeholders, you look at potential strategies to mitigate the negative impacts or harness the positive impacts. And I want to show you one that links to Rosalba's talk about different ways of enabling people to consent remotely. But more generally, I think it's about offering a variety of methods for people to partake digitally in your trial. So it's partly about different devices. So Rosalba said, for example, that her iConsent module was available on the web. So more people sometimes just like to be behind a computer rather than use their phone. But it might also be that instead of people having to type, it might be that they can, you just speak into an app and then the app translates it. Other things that I've learned from doing digital trials is that people often share devices. For example, if they're older, they sometimes have children or a partner who has a newer version smartphone, and they have a very old model and they just use it to call, their grandchildren. But often the procedures and the way that we design them is very much you have a device and it's your own device, and in that way we design our procedures. So just keeping in mind that people might be sharing devices or sharing an email address, for example. So lots of older couples have a shared email address. So if that's your way of communicating with a trial participant, it's something that you need to keep in mind. I think the other thing that lots of recommendations are about is maybe you should always offer a non-digital alternative if people struggle. So a phone call, for example, to do follow-up data collection. And then the last one is more about later on in the trial. Once you're up and running, make sure that the trial staff who are supporting participants know what they do. And there are quite a lot of studies that show that trial staff often don't feel up to the task if there's high digitization in the trial. For example, because there's a remote e-consent module, they have seen it once, but they have no way of showing it to people and talking them through it. Or there's an online form that has all kinds of logic underneath, and patients ask them questions that they just don't have the answer to. So I guess assessing people's needs, training needs, and then together with them designing the materials and support they need, I think is quite an important one to do. You do it in the early stages, but then obviously you see it through once you are conducting the trial. And I think, again, worked better this time. I think. Yeah. I'll get to my last slide with the take-home messages, which is basically a summary of what I've just been telling you. So I think the key things to keep in mind is when we talk about inequities, we talk about differences that we consider unfair and avoidable. And I think in terms of digital, they almost always are. When thinking about groups, relevant groups, think about those combinations of social and digital determinants of health. And then in the scoping phase of your equity impact assessment, identify the groups that you feel at the highest risk of experiencing them. Then there's this whole wealth of strategies. Have a look at those papers. Some are so simple, and I think they can make a huge difference in making your trial more inclusive. And then finally, I think working with stakeholders in a broader sense, and keeping them involved from planning till the very end into the data visualization, I think was on Carol's slide, will really help create an inclusive trial and therefore positive research impact. Thank you.